session. Thanks. Prof. Jaya, Dr. T, are you ready? We can start. Okay. Welcome, everyone. It's a pleasure to welcome everyone to the weekly webinar organized by the College of Physicians Malaysia. And this month will be on the month of endocrinology. And we are in the week 4. And today's topic will be on diabetes insipidus. We are very fortunate with us today. We have Associate Professor Dr. R. Jayakanta Analakiranasingam with us, and also Dr. T. Hui Ching. So without further ado, let me introduce Associate Professor Dr. Jaya. Dr. Jaya Kanta obtained his undergraduate degree from National University of Malaysia and his master's degree in internal medicine from University of Malaysia. He completed his advanced training in endocrinology with the Ministry of Health Malaysia and had undergone a fellowship in endocrinology at the Princess Alexandra Hospital, Brisbane, Australia. He also have a further attachment done under neuroendocrinology at the Auckland City Hospital Pituitary Centre in New Zealand and the Cambridge University Endocrine Clinic at Edinburgh Hospital in the United Kingdom. He is currently a senior consultant endocrinologist and also the head of endocrinology at University Malaya Medical Centre, Kuala Lumpur. Without further ado, I will pass the floor to Prof. Jaya.
Yeah, good afternoon, everyone, and thank you very much, Dr. Liu, for that very kind introduction. Thank you to the College of Physicians Malaysia for organizing a whole month of endocrinology-themed webinar. I think it's really exciting, and congratulations also to the organizers on deciding on this topic, diabetes insipidus, because it is really quite rare for us to encounter a CME activity just dedicated to DI. Many of us, I think, are really eager to learn from Dr. T today. Although we don't talk about it much, but it is a condition that we will encounter even as general physicians or, as medical officers. So I think it gives me great pleasure. I'm going to chair this afternoon, and over the next 1 hour, we are going to really take a deep dive into diabetes insipidus, and we are going to hear about our case illustrations, what the new terminology is for diabetes insipidus, because nowadays we call it AVPD or AVPR. I think Dr. T will tell us about it. And before we go into all of that, let me introduce our speaker, our star for the day is none other than, it's giving me great pleasure, Dr. T Hui Ching. She's a consultant endocrinologist at the Queen Elizabeth II Hospital in Kota Kinabalu in Sabah. Dr. T obtained her MBBS undergraduate from University Malaya, and then went on to get her MRCP from the United Kingdom, and she did her endocrine training and completed it with MOH and completed it in 2021. I had the opportunity to work with her in the years, I think probably it was 2020, maybe, or 2021, maybe during COVID. Yeah, so she's very, very widely published. She is leading the endocrine center in Queen Elizabeth II Hospital in Sabah, and she's beaming in all the way from there to tell us a little bit about diabetes insipidus. Dr. T, the Zoom is yours.
Thank you so much, Prof. Jaya. So I will share my screen first. So everyone can see my slide, right?
Yeah,
Very
you
good.
just need to put it in a slide view, I mean a presentation mode.
It is in a presentation mode already, right?
No, it's not. It's actually at I can still see all your other slides on the left. Yeah. Sorry about that. Just give us a second. Yeah, okay, that's good. You're good to go.
Okay, sorry for the delay. So a very good afternoon, everyone. So today I'm going to talk about diabetes insipidus. So this is the outline of my talk today. So I'll go through definition, classification, and etiology, diagnosis, management of DI, and we'll specifically talk about post-operative DI as well as active sick DI. So first, what is the definition of DI? So diabetes actually comes from the Latin words that means pass through, whereas insipidus means there's a lacking flavor. So diabetes insipidus basically means passing a lot of tasteless urine. So it used to cause diabetes insipidus. However, in 2022, Endocrine Society from US, European, Canada, as well as other countries had proposed to change the name to this AVP, arginine vasopressin disorder. This is because to avoid confusion with diabetes, and at the same time, it actually can reflect more properly the underlying pathophysiology of the disease. So the definition of this AVP disorder, it means is there's a production of abnormally large volume of hypotonic urine that is inappropriate for the state of hydration due to the deficient secretion of AVP or impaired action of AVP. So let's go through a little bit on the pathophysiological of AVP disorder. So when we are dehydrated, the osmoreceptor in the hypothalamus will be stimulated, and it will actually cause us to feel thirsty and drink more water to bring down back the plasma osmolality. At the same time, this osmoreceptor activation will stimulate the hypothalamus nuclei to produce more AVP and increase in plasma vasopressin level. And this plasma vasopressin will act at the collecting tubule level and increase water reabsorption. So in the case of AVP disorder, there will be decrease in AVP or impair in action of AVP, causing increased urine production and result in polyuria and sometimes even volume depression and hypernatremia. So classification of AVP disorder, it can be divide to AVP deficiency or AVP resistant. So AVP deficiency, used to known as cranial DI, is due to loss or impaired function of the vasopressingenic neuron in the hypothalamus or posterior pituitary, leading to impaired synthesis and secretion of AVP. Whereas in the AVP resistant, there will be an impaired AVP binding to the vasopressin 2 receptor, and hence causing a problem in concentrating the urine. So what is the etiology of AVP deficiency? So it can be due to familial causes such as X-linked recessive or the autosomal dominant. This DIDM OAD means diabetes insipidus, diabetes mellitus, optic atrophy, and deafness, which is very rare. The common cause would be surgery, iatrogenic, usually surgery for the pituitary adenoma or any cellular or supracellular lesion. Neoplastic usually can happen in craniopharyngioma or geminoma, other lymphoma, leukemia, and pituitary stalk metastasis as well. So bear in mind that our common pituitary adenoma is seldom cause an isolated AVP deficiency unless it's very extensive, or in the case of post-operative stage, that usually will also associated with other hormone deficiency. It also can be due to traumatic brain injury or vascular cause like subarachnoid hemorrhage, ICB, or even Sea-Hunt syndrome. Infection such as sarcoid, histio, granulomatous disease, TB, HIV disease, COVID-19 infection. Autoimmune causes or central nervous system malformation include our empty cellular syndrome and also pituitary hypoplasia. And sometimes it can be idiopathic as well if we have ruled out other causes. Whereas for nephrogenic DI or AVP resistant, it also can be due to hereditary causes, either the gene mutation or in the Bartter syndrome. And more commonly, it will be due to medication such as lithium. And metabolic causes, hypercalcemia and hypokalemia is also not an uncommon causes of our AVP resistant. Kidney disease include urinary tract obstruction, autosomal dominant polycystic kidney disease, medullary 60 kidney disease, renal amyloidosis. And this last part, pregnancy actually is not really categorized by either group. It's specifically usually due to vasopressinase enzyme that cause an increased breakdown for the ADH rather than reduce in synthesis or resistance. So let's move into diagnosis. Let me start off with the case first. So we have this 70-year-old gentleman with no medical illness. He presented with 3-month history of polyuria, polydipsia, and nocturia. So does this patient have DI? So how do we diagnose? So before we go into diagnosis, first we should know what is the causes of polyuria. Generally, we can divide either into solute diuresis or water diuresis. Solute diuresis can be due to uncontrolled diabetes, mannitoluria when there's a resolution from the AKI, sodium when there's an intravenous volume expansion or release of bilateral urinary tract obstruction, or diuretic. Whereas water diuresis, it can be due to primary polydipsia or AVP disorder, either deficient or resistant. So what are the clinical features? All patients will have polyuria, polydipsia, and nocturia. So there are certain features will help us to think more likely of a primary polydipsia. This include gradual onset, when patient had the daytime symptoms but can have a uninterrupted night sleep without nocturia. When there's an associated psychotic disease, as a primary polydipsia can happen in 20% of patients with schizophrenia. So features that points towards to AVP deficient disease include constant need for fluid intake at night, and they tend to crave for cold water. And usually the onset is abrupt, and if there's a headache or visual disturbance, it points toward underlying intracranial lesion. If there's any traumatic brain injury or surgery previously, and if there's any other autoimmune features, they will point toward autoimmune hypophysitis. Features that's supportive of AVP resistance would be a very obvious drug history or any features that's suggestive of hypercalcemia or hypokalemia. So what is the step in diagnosing DI? So first of all, we must confirm polyuria. So this is defined by more than 50 ml per kg or more than 3 liters per day. This is very important as some patients when they complain of polyuria, but instead actually the urine volume is not increased. So instead they're actually having a increased urinary frequency rather than polyuria. So we can confirm this by asking patient to measure a 24-hour urine volume. So next, we can go through the clinical features, measures the serum osmolarity, urine osmolarity, pair with the renal profile, electrolytes, and glucose. So let's say the urine osmolarity is less than 300 milliosmol per liter. It usually means water diuresis. So in this group of patients, if their sodium is low with the markedly diluted urine osmol of less than 100, we can diagnose primary polydipsia. Let's say the sodium was concentrated, sodium was high with a plasma osmolarity more than 300 at the same time of diluted urine, we can diagnose patient having a AVP disorder. If the sodium and plasma osmolarity was normal, we can proceed with water deprivation test to differentiate between primary DI, primary polydipsia, and AVP disorder. In the case of urine osmolarity more than 600 to 800 milliosmol, is usually due to solute diuresis. If the urine osmolarity is intermediate around 300 to 600, we can proceed by doing this, calculate this total daily osmolar output in which we can measure urine osmolarity times the 24-hour urine volume. So if it's less than 1,000, it points towards water diuresis, and if more than 1,000, it points towards solute diuresis, and we can further investigate as previous what I mentioned previously. So what is water deprivation test? Basically, it's a test that we do to differentiate between primary polydipsia and AVP disorder. So what we do in this stage, in stage 1, we'll try to dehydrate the patient. And normal people, when we dehydrate a patient, the urine can concentrate. Whereas in patient with AVP disorder, the urine cannot concentrate. So basically, this stage 1 used to differentiate these two groups. In stage 2, we look at the response to the desmopressin. In the case of AVP deficient, there will be response, whereas in the case of AVP resistant, there will be no response, less response. So if the patient already have a baseline high plasma osmolarity, hypernatremia, and the urine osmol is hypotonic, the primary polydipsia especially can be excluded, and we can straight away go to stage 2. The patient no need to go through stage 1 again. It's very important for us before we proceed with water deprivation test is we must rule out other obvious causes, for example, osmotic or other electrolyte imbalance. We also must treat the underlying anterior pituitary hormone deficiency, as the steroid or tyrosine deficiency can impair excretion of free water lot. So if it's not treated, it will make the test inaccurate. So this is just showing how we do the stage. So basically, we will measure we'll ask patient to stop drinking water, fast the patient for at least 8 hours, measure the urine volume, wet the patient, send the urine osmolarity hourly, and send plasma sodium and serum osmolarity 4 hourly. So in any time, if the urine osmolarity able to concentrate to more than 600, so we can almost exclude DI, so we can stop the test, because means patient have a normal concentration ability. If any time when there's more than 3% weight loss, or when there's hypernatremia or serum osmolarity more than 300, we can confirm DI, we can proceed with stage 2 earlier. So in stage 2, what we do is we will give a mini read, and then we will measure urine volume and urine osmolarity hourly for 4 hours. So this is how we interpret the result of water deprivation test. So for stage 1, water deprivation, so as I mentioned previously, normal patient or even primary polydipsia, the kidney able to concentrate the urine, usually up to more than 600 with the normal serum osmolality and plasma sodium. However, in the patient with a chronic primary polydipsia or partial DI, the urine osmolality result can be ranged to 300 to 600 with the normal serum sodium and plasma sodium, serum osmo and plasma sodium. In the case of AVP disorder, the urine osmolality will be less than 300 with the plasma sodium of more than 145 or serum osmo of more than 300. So in stage 2, we will see the response after the mini-urine. So in chronic primary polydipsia or partial DI, usually they will have no or partial response. Whereas in AVP deficiency, there will be increase in urine concentration for more than 50%. In the case of AVP resistant, the urine concentration will increase less than 50% after mini-urine. So the diagnostic accuracy of this water deprivation test is only about 70%. It's actually quite low, and even lower for about 40% in the case of primary polydipsia. There are a few reasons for that. First, in patients with chronic primary polydipsia, they may not maximally concentrate the urine despite a rise in plasma AVP concentration, as over drinking will suppress the AVP secretion and the intracellular aquaporin store are depleted. So sometimes they can be misclassified as partial DI. Whereas in the patient with partial AVP deficiency, the residual AVP secretion can induce urinary concentration. And this is possibly due to upregulation of the vasopressin receptor and hence result in difficult to distinguish from primary polydipsia. In some cases of AVP resistant, the elevation in the plasma AVP concentration in response to water deprivation sometimes can be sufficient to partially overcome the renal resistance and also will result in diagnostic confusion. So is it other better test? So actually, in many countries, they have been using COPM instead. So COPM basically is an inert molecule that cleaves from the AVP precursor. It's correlated well with the plasma AVP level in the physiological and pathological stage. So why can't we measure ADH straight away or AVP straight away? Because AVP is actually very short half-life and is not commercially available in the lab. So we can send the baseline COPM. If it's less than 2.6, we can diagnose AVP deficiency with 95% of sensitivity and 100% of specificity. Let's say the baseline COPM is more than 21.4, we can diagnose AVP resistant with 100% sensitivity and specificity. Let's say it's less than 21.4, we can proceed with a stimulated COPM test. So usually we'll do this by doing a hypertonic saline infusion to M sodium of more than 147. If the simulated COPM is less than 4.9, we can diagnose partial cranial DI. If the simulated COPM is more than 4.9, we can diagnose primary polydipsia. So once we confirm the diagnosis of AVP disorder, we should proceed with evaluate for the causes. In the case of AVP resistant, usually the drug history will be apparent. Sometimes we also can order ultrasound KUB to look for any structural problem and or even genetic tests. In the case of AVP deficiency, we should proceed with the MRA pituitary protocol and pituitary hormone panel. So in a AVP deficient condition, there will be a loss of posterior pituitary bright spot, which represent a depletion or absence of the stored AVP granules. However, this feature is not specific and not sensitive, as older patients might have a loss of bright spot despite a normal AVP secretion. And in some patients with DI, they can have a normal posterior bright spot as well. If there's a thickening of pituitary stalk with an absence of bright spot, it can point towards idiopathic or autoimmune causes. So if there's any mass, we can think of either craniopharyngioma, any granuloma disease, or inflammatory or infiltrative causes, or other metastasis. So this just to show what is the normal bright spot at the posterior pituitary, as shown in the left. And in the right, we can see there is no bright spot at the posterior pituitary. So this one usually we have look at the T1 sagittal view at the non-contrasted film. So back to our case. So this patient have a documented polyuria of more than 4 liters per day, and he need to drink more than 5 liters per day. There is no preceding trauma, headache or blurring of vision, or other pituitary hormone deficient symptoms, no autoimmune features or considered symptoms. Past medical history, family history, and drug history is unremarkable. Examination was normal. And the blood result actually show that patient have a normal sodium with a urine osmol of less than 300. So this will point toward a water diuresis. So we have ruled out other causes like by showing a normal potassium, calcium, and your blood sugar level. So this patient, we proceed with water depression test to further differentiate from primary polydipsia versus AVP disorder. So this is the result. You can see that when we water deprive the patient in the stage 1, you can see the body weight actually show gradually reduce. But usually normal people, the urine volume tend to reduce when we deprive the patient from water. But you can see in this patient, the urine volume still quite a lot despite water deprivation. And look at the urine osmol, it also didn't concentrate much. So at around 1 p.m., when the sodium was high, we terminate the case because this confirmed the diagnosis of AVP disorder in which sodium high and urine osmol less than 300. So means the patient cannot concentrate the urine. So we proceed with stage 2, we give mini-urine, and the urine osmol able to concentrate more than 50%. So this support the diagnosis of AVP deficiency or central DI. So other pituitary hormone was sent for this patient, all normal, and he even have a normal MRI brain. Other autoimmune marker was sent to rule out autoimmune causes, and also tumor marker was sent to rule out germinoma. All was negative. Here, the repeated MRI 1 year later show a thickened pituitary stalk, and the subsequent MRI was stable. He developed hypogonadotrophic hypogonadism 1 year later and central hypothyroidism 2 years later. So our inpatient for this patient is a possible autoimmune hypophysitis with partial hypopituitarism. This just show the MRI for this patient. So usually pituitary stroke should be less than 4 mm at the insertion of the optic chiasm. Usually we should measure at the sagittal view. So in this patient, you can see it's around 6.99 mm is the thicken. So this patient was started on minirin, tyrosine, and testosterone. She is not keen for biopsy or pulse steroid that can help to differentiate either infiltrative or autoimmune causes. So we decided just to proceed with MRI and pituitary hormone surveillance annually. Okay, let's move into the next topic, management. So first, I will talk about management of fluid intake. So patient with DI, usually they will have an intake thirst control. So even if they're having a polyuria, usually what will happen is your urine osmol will increase. If they have a normal thirst control, they will feel thirsty and drink more water to repress the renal water loss. So usually they seldom go into hypernet or dehydration state. So we just need to encourage patient to drink to thirst. However, we must educate them on sick day rules as well. So they should increase fluid intake in the GI losses and seek medical attention early. So for pharmacological management, it will be desmopressin. So desmopressin basically is a synthetic analog of AVP. So it is actually modified to have a prolonged half-life compared to our AVP. And it also eradicate the vasopressor action of the AVP. So vasopressor action basically will cause vasoconstriction. So this makes desmopressin relatively safer. The adverse effect include overload, hyponatremia, and other arterial disease. This table show different formulation of our desmopressin and the dose equivalent. We used to have a tablet and spray, nasal spray, but now generally we are using sublingual as in Malaysia, as the company is not producing tablet in intranasal spray already. So sublingual have the advantage of rapid onset and also more stable absorption compared to tablets, and also the better bioavailability. Whereas for the injection, it can be given as a sub-Q or intravenous, and usually will be used in the acute setting. So this desmopressin is actually the action is duration of action is a dose dependent. So the higher the dose, there's actually a longer half-life. This has been shown by William et al. In his study. So next, let's move into inpatient management. So there are a few contexts we should focus for inpatient management. First, we have to assess the fluid status, look for any hyponet, and fluid resuscitation if needed. So how much fluid to give when the patient with a known case of AVP disorder develop hyponet? So total fluid to be given can be calculated by this water deficit plus extra loss plus maintenance, which usually about 25 to 30 ml per kg. Water deficit can be calculated from a lot of medical calculator. We also should monitor the serum sodium and urine output closely. Whenever patients start pouring, we must repeat the serum sodium more frequently, as there's a risk of increase in sodium rapidly. Next, choice of fluid. What fluid to give when patient develop hypernet? Let's say patient is euvolemia, we can consider dextro drip, hypotonic fluid. Let's say patient hypovolemia, we tend to choose fluid with sodium content, either quarter saline or half saline, to maintain the intravascular volume, and even isotonic saline if the patient is hypotensive. We should change to oral or nasogastric fluid as soon as possible, as this is actually the most safe method to prevent rapid change in the sodium level. If the patient already on regular minimum dose and the normal sodium and patient was stable, the fluid to give is actually as a normal patient. Next, about the desmopressin administration. So acute setting, we will give a sub-Q or IV 1 to 2 mic PRN, and we'll change to regular dose once patient stable. We also should avoid overcorrection. Keep it less than 10 millimole change per day to prevent ODS, osmotic demyelinating syndrome. Let's look into in the chronic AVP disorder, how do we manage? So in normal patient, in healthy human, when we drink fluid, we will suppress the AVP secretion. So we will then allow an accuracies to prevent water retention and dilutional hyponatremia. However, for patients with AVP disorder on regular mini-urine, they will have this constant antidiuresis effect. If they have any excess fluid intake, they will develop hyponatremia. So there are a few studies that show few methods that prevent hyponatremia by allowing intermittent accuracies. So we can, by doing a delay dose, once or twice per week, meaning delay until accuracies develop, or we can have a regular delay dose in which we will delay every dose of minerin until after polyuria develop. Or we can do this weekly omission of a tablet. So for example, if the patient is on sublingual minerin 60 ml BD, we can ask patient to omit Sunday morning dose, so to allow excess water to pass out. This is highly effective, but it can be inconvenient if a significant polyuria interrupts the works or other activities. How about AVP resistant nephrogenic TI? How do we manage? First, we should treat the underlying cause, hypocalcemia, hypokalemia, and stop the offending drug. You can also try restrict the salt intake to less than 2.3 gram of sodium and a protein intake of less than 1 gram per kg. This will reduce the solute excretion and hence reduce in the urine output. We can also try diazide to induce mild volume depletion, amiodaride as a monotherapy or combined with the diazide in the case of lithium nephrotoxicity. Acetazolamide also have been used previously. NSAID usually more useful in the case of a Bartter-like syndrome when they involve the prostaglandin synthesis mechanism. And lastly, desmopressin also can be used in some patients. By giving desmopressin, actually we can attending a supraphysiological hormone level, and this sometimes can increase the kidney effect of the ADH to a clinical important degree. Let's move into next topic, adhesive DI. As I mentioned previously, most of the patients with AVP disorder, they have an intact thirst sensation. So they rely on normal thirst to generate water intake to maintain hydration and eunatremia. However, in small number of patients, the lesion that cause the AVP deficiency also damage the osmoreceptor in the anterior hypothalamus. And this will causing a impaired thirst mechanism and leading to adhesive DI. So this group of patients tend to develop hypernatremia and dehydration, and they carry high mortality and significant morbidity. So how do we manage this group of patients? So first, we should fix the fluid intake. We can try with 30 ml per kg, usually with a daily fluid intake of 1.5 to 2 liter. After that, we should start patient on regular dose of desmopressin to fix the urine output. Then we can adjust accordingly according to the sodium and also the urine output. Once a baseline eunatremic weight is established and the plasma sodium is stable, the variation in fluid intake can be calculated on the basis of the climate change, physical activity, or any intercurrent illness. So patients are advised to wet themselves. If there's sudden drop from the eunatremia weight, this may mean dehydration. So we should encourage patients to increase hypotonic fluid to replace the fluid deficit. If the sudden weight gain, it may reflect fluid overload and the risk of hyponatremia. We should send sodium and consider withhold minerin and reduce hypotonic fluid if hyponatremia. So let me illustrate a case of adhesive DI. We had this 22-year-old gentleman. He presented with lethargy and slow in response for 1 month. Further history also noted polyuria and polydipsia for more than 2 years. However, it's worsened for the past 1 month with more than 5 liters per day of polyuria. But patient did not feel thirsty, so there's reduced in water intake. So in ED, patient was confused, hypotensive. After given fluid bolus, the BP normalized. The initial blood investigation showed hypernatremia, sodium of 161 with a diluted urine osmolality of 114. So with this and the high serum osmolality of 241. So with this, we can diagnose patient having a AVP disorder. So this patient was given desmopressin. The urine osmolality after desmopressin able to concentrate more than 50%. So all these points toward a AVP deficient disorder. CT brain was done that show a solid cystic supracellular lesion with an obstructive hydrocephalus. and other pituitary hormone sense show hypocortisolism. T4 low with inappropriate normal TSH, which show a central hypothyroidism. Testosterone low with an inappropriate normal FSH and LH, which show a hypogonadotrophic hypogonadism. IGF-1 was low as well, and the protein was 3 times upper limits. So this prolactin of 3 times upper limit is unlikely is unlikely due to prolactinoma, as patient having a large lesion. As in case of macroprolactinoma, the prolactin level usually more than 10 times upper limit. So in conclusion, this patient have a supracellular lesion with a panhypopituitarism and having a hyperprolactinemia due to stalk effect. This is the patient MRI. So there is a large supracellular lesion, which is a heterogeneous intensity in the T1 plan MRI, and is a heterogeneous enhanced. There's also presence of obstructive hydrocephalus. Just sum up a little bit on the progress of the patient. So on day 1 of patient was hypernatremic with polyuria. So he was started on a hypotonic B5 and encouraged orally. He also started on regular minimum dose sub-Q 2 mStat and 1 mBd. After that, you can see that sodium slowly reducing with the reduction in the urine output. Hence, the IV drip was cutting down. And in day 4, the sodium normalized and patient was relatively stable. Hence, it was changed to a sublingual 60 mBd, sublingual desmopressin 60 mBd. So as I mentioned previously, in the case of active sick DI, we will try to fix the oral intake. So in this patient, we try to fix into 2 liter, and we start patient on regular minirin and monitor closely. So you can see from day 4 to day 6, with the fixed water intake and the fixed minirin dose, the urine output is slightly at the high side. And even in day 7, patient go into the hypernatremic with pouring actually for this level actually pouring for this patient. So in this stage, we decided to increase the minirin dose to 60 and 120 mic and continue the same fluid intake. So after that, we can see there's a normalization of sodium with the same dose of minirin and fluid intake, and we also can note that there's a reduction in the urine output. So this patient is because as I mentioned previously, had a panhypopia, it started on steroid and thyroxine replacement, proceed with OP, and the HPE show germinoma, and he still had persistent cranial DI after operation. So the final impression was a germinoma with a panhypopituitarism with a component of active DI. He was having ongoing antibiotic for HAP and M for chemoradiotherapy once the patient stable. Okay, lastly, we'll talk about post-operatively DI. So there's no consensus guideline on how do we confirm the diagnosis of post-operative DI. But generally, there are few parameters we can look into. First, polyuria. There are actually different definitions in different paper, but usually we can use more than 300 per hour for at least 2 to 3 hours. There will be a negative fluid balance. There will be a diluted urine with urine SG of less than 1.005 and urine osmol of less than 300. Plasma sodium and serum osmolality can be normal if patient have a normal thirst center and can access to the water. And very importantly here, we have to exclude other causes of polyuria, especially if a patient was given excessive intraoperative fluids, in the case of hyperglycemia or given diuretic therapy or even mannitol. And don't forget, in the patient with acromegaly, when there's a rapid decrease in growth hormone, they also can cause in excretion of a lot of free water. So there's actually this proposed definition of post-operative DI published in Pituitary 2021. So in this article, they propose that we can use this criteria. So patient must have hypotonic polyuria, which defined by urine production of more than 300 ml per hour for 3 consecutive hours, and urine SG of less than 1.005. And at least one of the following, which includes excessive thirst with the numeric rating scale 6 or uh, 6 more than 6 or more or equal to 6 out of 10, serum osmolality of more than 300, or serum sodium of more than 145. So the incidence of post-operative DI it range from 0.3 to 45%, depends on the center, and it can be partial or complete. The onset usually is abrupt and generally occur within 12 to 27 hours post-operatively. Most cases are transient and resolve within 3 to 5 days post-operatively. Rarely, patient will have this triphasic or biphasic response. Triphasic means they will develop a polyuria, then at SIDS stage, then polyuria again. Whereas in biphasic, they will having a DI and SIDS stage. Prolonged cranial DI can present for 2 weeks to 6 months, or chronic persistent AVP deficiency can present for more than 6 months after operation. This can occur in 0.9 to 10% of patients. So let's go through why we have this triphasic response. They are quite specific for patient of a post-operative DI. So as we all know, the ADH, AVP will be synthesized in the hypothalamus nuclei and will be transported down through the axon and stored in the posterior pituitary. So in this first phase of this triphasic response, there's an injury to the pituitary stalk. So this will cause a reduced ADH release from the deposit. So this early polyuria phase can last within 24 to 48 hours after surgery. So after that, there will be a degeneration of neurohypophyseal axon. And with this, there will be increased ADH release from the stored ADH in the posterior pituitary. So this will result in a antidiuretic phase. Excessive ADH can cause increased water reabsorption and sometimes result in hyponatremia. Usually start 5 to 8 days after surgery and last for 2 to 5 days. And lastly, we'll have this late polyuria phase again. So this happens in patients that have persistent damage when all the ADH deposit in the posterior pituitary have been depleted. So they will become polyuria again. So what are the risk factors for post-operative DI? So there are a few predictive factors that have been identified previously. So just to focus here, usually the craniopharyngioma, Raffkes crest is more common associated with that. Patient with larger tumor, suprasellar extension, or having a gross, very extensive resection, history of previous surgery, younger age as well. And Amanda et al. Have been proposed this SOT score for predicting post-op DI. So looking into 4 components: S for suprasellar extension, A for age less than 50, C for craniopharyngioma, and T for Kelly grade 3 lead. This basically is an intraoperative CSF lead. So in his study, he showed that the higher the score, the higher rate of getting post-operative DI. So we can look into this risk factor and anticipate DI in our patient post-operatively. So how do we manage in the post-op DI? So in any patient after pituitary surgery, we should monitor renal profile, urine output, urine SG, and osmolality closely. If we confirm the DI, especially in the early post-operative stage, we usually will give desmopressin in the PRN basin. Especially, sometimes we don't need to give if patient can drink to thirst. We tend to give if the urine output is excessive, when there's hypernatremia, patient is sedated or unable to maintain adequate oral fluid, or in the case of atopic DI. Usually they can resolve after a few doses of IV desmopressin. We must cautious to avoid over-treatment will result in hyponatremia, especially if the patient develop a second SIDH phase. If the AVP deficiency persists beyond 48 hours, we can change the patient to a regular sublingual desmopressin dose range from 60 to 120 mic on night to TDS. They should be tested for recovery of posterior function at 3 to 6 months after, as 80% of the patient have a restoration within 3 months post-op. Long-term recovery is very rare, but have been reported as well. So let me illustrate this post-operative DI case. So we had this 61 years old female, is a known case of, newly diagnosed and non-functioning pituitary adenoma, electively admitted for transvenoidal surgery. So he initially presented with headache and blurring of vision for 1 month. Examination show bitemporal hemanopia. Hormonal profile was normal. Renal profile was normal as well, and patient did not have any diabetes insipidus before operation. This is the MRI of the patient. You can see here this iso-intense homogeneous vision with extend to the suprasera and compression of the optic chiasm, and is also enhanced in this coronal view. So we can see when, as we mentioned previously, when there's a suprasellar extension, there's a higher risk of getting post-operative DI. So let's read into the progress in the ward. So TSS done. So during day 1 and day 2 of operation, there's an episode of polyuria noted. In our center, we use a cutoff of urine output more than 200 cc per hour for more than 2 hours. So during this time, we'll send the urine SG, osmolarity, serum osmolarity, and renal profile. So in this patient, during the pouring time, patient have a diluted urine osmol of 174, and day 2 is urine osmol 85. So together with the excessive thirst, this support the diagnosis of diabetes insipidus. And even in day 1 post-op, patient had the sodium up to 146, hypernatremia. She actually given sub-Q desmopressin, and after that noted the urine able to concentrate. So after that, from day 3 onwards, we can see that urine output gradually reduced. There's no more episode of significant polyuria, and the sodium was able to maintain normal as well. So this patient having a transient cranial DI. Need to mention here, highlight here is in some patient of after TSS surgery, they will put on a nasal bag. So sometimes they will breathe through mouth, and this sometimes will reduce in dryness, and they tend to drink more water. Kind of they will induce in the stage of something like primary polydipsia, drink more water, and hence passing out urine. So you must differentiate properly between the causes of it. Is it due to excessive drinking, due to thirst, or due to the dryness? Okay, take home message. So first, for diagnosis, we should know how to differentiate water versus solid diuresis, differentiate primary polydipsia versus AVP disorder. And once we confirm AVP disorder, we have to know how to differentiate AVP deficiency and resistance, and investigate the underlying cause. For the management, we should treat the underlying cause, and sometimes by treating the underlying cause, it can revert the DI. for minerin replacement, especially in chronic case, we should consider skip dose to prevent hyponatremia. Fluid management is very important, and also seek day rules. And in the case of active CDI, we should remember we should fix the minerin dose and also the fluid intake. So sometimes when we adjust, we try to adjust only one thing rather than adjust both minerin and fluid intake. That's all for my presentation. These are my references.
Thank you very, very much, Dr. Ti Hui Ching. I think that was really a very nice and elegant overview of AVP deficiency as well as AVP resistance that you take us through beautifully from, diagnosis, differentials, how to come up with the confirmatory test, what are the treatment options available, as well as some of the little nuances. I think really you covered everything very, very well. I don't see any questions yet in the Q&A box, but I think, yeah, I don't see there's only a comment there. Excellent presentation. Yeah, congratulations, switching. Excellent presentation. Yeah. So I don't see any questions yet, but I sort of like want to discuss something. I mean, if there's no other questions, I think, have you had experience, Hui Ching, with patients who, because we know now we all use the mini-rin melts or the, the DDAVP melts because we don't have, because the company has decided that that's the best mode of delivery. And sometimes we do use half tablets. In the past, we have used 0.05 milligram, and that actually will equate to 30 micrograms. So have you had experience of splitting the melts to give to
Yeah,
some patients? Yeah.
we actually encountered this problem as well because the minerin, the tablet is very small and it's very fragile. When we cut it, it sometimes will break into a powder form. It's not we're not sure whether about the bioavailability already. So sometimes in this type of patient, we'll rather sometimes we'll consider if we need lower dose, we'll consider EOD dosing or less frequent dosing.
Yeah.
And sometimes it's really not easy to manage active sick DI with those patients with partial DI. They don't need high dose, but quite difficult to get to the dose.
Yeah, so I think a lot of it is, you really have to individualize, isn't it? Because different patient may need different. You may notice different experts or endocrinologists may actually sort of adjust the doses differently in different patients, and also it will depend on the patient's amount of fluid intake as well. And like you correctly pointed out, many of us also do the omission once a week. I do that quite often in my patients as well to prevent hyponatremia. So I think for the general physicians, really the take-home messages, I mean, there's no questions in the Q&A box, but I think just want to summarize a few things. I think, when we see polyuria, I think we really need to, I think the first thing is before we jump into conclusions or biochemistry is actually to look at the patient and determine the hydration status and really go through what the input and output is, like you correctly pointed out, because a lot of it could be patients drinking a lot, even post-pituitary surgery, because they have dry mouth from nasal blockage, they could be drinking a lot. And many patients can't tell the difference between dry mouth and thirst even, even doctors can't tell the difference sometimes. So we just drink and drink and drink. So it's very important for us to look at IO. And also for many of you, I think you guys are from all over the country. It's similar, I think, even in MOH or in MOE kind of hospitals also, there is sometimes there's lack in attention paid to input-output charting. The nurses may not find it as important, but in this kind of situation, it's really, really important. And you guys, as doctors in your own field, wherever you are as physicians, I think really need to emphasize to your nurses and your ward the importance of input-output charting. Because even in my hospital, there could be chartology that happens, kencing banyak, kencing sikit kind of thing. It happens all over the country, all over the world. It happens, in fact. Yeah, so I think that's very important for us to stress. Look at the IOs and always think of common causes of polyuria. Also, like you very beautifully you showed hyperglycemia, hypercalcemia, hypokalemia. These are the amount of fluid that patient has taken. These are very important other things to look at before you jump into the conclusion that this could be diabetes insipidus or AVP deficiency or resistance. I think that's mainly the main thing I want to emphasize on. And if you really do encounter diabetes insipidus, I think, Dr. T has given us a beautiful overview on the test that we could do, like what, of course, the basic biochemistry from the osmolarity, from the from the sodium levels or the specific gravity of the urine. And then on needing, sometimes you may need confirmatory tests like water deprivation, sometimes you don't need it. And also now we have COPEPTIN. I don't think it's being done in any hospital on the public side, but in some of the private labs, we have done it a few times. The private labs in Malaysia does offer the service, so it can be sent off for COPEPTIN level as well. And anything else you want to add, Dr. T or Dr. Liu?
I think so far, okay. I do have one question for the T. Like those for post-operative DI, we suspect that it's post-operative DI, we decided to give milirine. And how frequent we should monitor back the sodium, the urine, and then to decide further how frequent we should monitor.
Usually, we will always measure urine output hourly still. And for the renal profile, we tend to repeat at least 4 hours after. Depends on whether patient have an abnormality or not. So you have to individualize. If the patient having a pouring again, you might need to repeat earlier. And sometimes even if a patient stable, you can reduce the frequency of the monitoring. How about Prof. Jaya?
Yes, I completely agree. It really, like you said, it has to be individualized. Depends on the severity also. Of course, if your sodium has gone up a lot, and then you're worried what the next level is, then you might want to do it a bit more earlier. But if it's not so serious, in some patients are quite well post-pituitary surgery. You may not need to, do it so frequently. So it really has to be individualized in that manner. Having said that, I think nowadays most centers, including for us in UM also, we are actually discharging patients quite soon after pituitary surgery because we do quite a number. In terms of volume, I think in my own center, we do close to 100 pituitary surgeries a year. That is both in the private as well as the public setting. So we are starting to now discharge patients earlier, like something like day 3 of post-surgery, and then see them back around day 7. Because as what Dr. T showed us, that's when you may actually end up with if you're in the triphasic or biphasic sort of response, you might end up with low sodium around that time. So that's when you actually need to monitor the sodium. So you can give them advice. Now I have myself started giving minirine tablet melts as spare for patients to keep at home and for them to measure their urine, and if they require it, they can take it. But of course, we need to see them back soon, around day 6 to day 8, day 7. We need to measure their sodium again and then look at their urine output. So if you have close communication with your patients, sometimes these things can even be done as an outpatient setting. In many pituitary centers around the world, is done sometimes as an outpatient setting. Like by 48 hours, they may even discharge patients.
Thank you, Dr. T, Prof. Jaya. I think we can call it a day. Okay, thank you, everyone.
Thank you very
Prof.
much.
Jaya. Thank you,
Thank you,
Liu.
Dr. Liu. Thank you, Dr. T. Yeah, and I see you all. Bye-bye.
Bye.